the University of Cologne, who really is a worldwide expert in coronary and structural intervention. And I've gotten to know very well over the last few months. And Matty, I hope we can collaborate more. The work you're doing is incredible in Cologne.
Thank you, Azim. You're too kind. I mean, I'm the one honored to be invited here and to have the opportunity to speak to you guys in the Monty Hard Cat conference. Quite a legendary thing to do. So I'm very, very honored to do this. And you guys are either lucky or not. Tell me in the end, because I'm allowed to talk about a topic that's very close to my heart. It's aortic regurgitation. So it's a lot of slides and a lot of information, a lot of data I want to share. So let's see if
Hi.
you find the next 30 minutes useful, okay? So if we, full disclosures, by the way, I also am a proctor for some dedicated devices for AR. So you might want to take everything I say with a grain of salt, but I am, it is about aortic regurgitation, not the valves so much. So if we go to aortic regurgitation, what are the basics? To be quite honest, that we don't know so much was for me, when I went to TCT and spoke about primary and secondary AR, Maurice Enriquez Serrano kind of disagreed. There is no secondary AR. So I think we already can start in the beginning, the first slide, to argue what is actually known about AR. How do we classify it? But one way to look at it is there are primary ARs, for example, after rheumatic fever, after endocarditis, and after other inflammatory disorders. There are also, if you want to call them that way, secondary AR, which are due to aortic root dilation, they're age-related, they're Marfan syndrome patients, they're Reiter syndrome patients, and there are patients that have an acute disease progress, like an aortic dissection or aortitis. You can also kind of use the Carpentier classification for it. If you, for example, look at the bottom right, in aortic regurgitation, there's a type 1 with normal cusp motion, then there's a type 2 with excessive cusp motion, and there's a type 3 with restricted cusp motion. Overall, rheumatic fever is the most common cause in the developing world, and in the US and Europe, I think congenital bicuspid AVs or degenerative disease is the most common mechanism. Let me see if I can laser pointer also. Perfect. The basics of the ventricular function, because one of the things that I really want to stress while explaining this is I think that AR also is a disease of the ventricle and not only of the valve. But why is that? Because it's a volume overload of the left ventricle in the end. If you have mild AR, LV size, function, and hemodynamics are usually normal. If you have an acute and severe AR, there's usually equibrillation of aortic and LV pressures. Of course, that's a very bad situation for a ventricle to be in, and those patients usually need very fast treatment. If it's a chronic severe AR, then the LV might begin to dilate. I think we can all agree that it's not the best thing to happen for an LV. But the LV ejection fraction is often maintained in the normal range, and I think that's important. And that is because preload is increased. There's systolic arterial hypertension and a wide pulse pressure. Also, pulsus cela et altus, if you want to, focus on your Latin a little bit. But the LV filling pressures are normal or slightly elevated only because the ventricle still is compensated. Once it's decompensated, the LV will dilate even more and will sometimes show some hypertrophy. Forward output is decreased in the end, leading to fatigue and other low output syndromes. And in this stage, you have fibrosis and a decrease in LV compliance, leading to further increasing of filling pressures and dyspnea. As shown here, and this is from from Braunwald. What I like here is it's a little math game. This is regular ventricle, and you have an ejection fraction of 67% here with an LV EDP of 10 millimeters mercury. If you add a significant AR, which means you have 150 cc forward and 75 cc backwards volume, this will change your LV ED pressure from 10 to 25. So it's 2.5-fold. This only comes down to a decrease in ejection fraction of 50. So it's a severe increase of filling pressures with a still maintained ejection fraction of 50. But look at the EDV. That's 300 compared to 150. That's almost doubled. So the volume is really a problem for the left ventricle. But you know, what I'm telling you, is it actually common, or what's the prevalence, guys? Come on, let's be honest here. Is that something that happens, or is it just a rare thing to happen? Well, if you look at the Framingham study, 4.9 of all patients, including trace and 4.9 of all patients had AR, including trace and mild, and 0.5 had moderate to severe AR in the Framingham study, which you know is not a very selected group of people. Over 2% had moderate or severe AR in patients that were older, and age was an independent predictor of AR. If you, for example, look at more recent data, then you see that one of the studies that has shown recently the prevalence of AR is the Oxford Register. So that's people that come to the hospital and they're asymptomatic. They don't have anything, they just get an echo. And you see that the number one thing you find is tricuspid regurgitation. The number two thing you find is mitral regurgitation in 2.3% of the patients. And in 1.6% of the, not patients, of the people that are getting an echo is 1.6%. So it's the third common reason you'll find as a moderate or severe, like a significant structural heart problem is AR. Of course, I mean, to be honest, where are all the aortic stenoses? I don't want, you know, I'm not the one trying to sell that AR is more common than AS. I think we can agree. But these patients are symptomatic. So the asymptomatic patients only have mild aortic valve disease and sclerosis and stenosis. Once they become severe, I think they're symptomatic and therefore not, you know, they're not in this population of patients. Same is true for the heart of New Ulm. You see that aortic regurgitation is the number 3 finding in patients that are getting echo when they're asymptomatic. So it's probably more common than we think. And how do we quantify it? So if you look at the echo guidelines, then we have qualitative parameters, we have semi-quantitative parameters, and we have quantitative parameters. All of them are more or less complex. Some of them are easy, some of them are yes and no, but they're, you know, everybody who has done echo knows that I've never seen a patient where you can get all these values perfectly. So it's kind of like a, you know, it's an equilibrium of good and bad. So I think it's really hard to get all the parameters, but there are clear definitions when it's moderate to severe, when it's severe. And, you know, I think all of you have seen this before. But if you look, for example, one of the last recent studies looking at AR, was a line, we're going to look at this a little bit further down the line. But if you look at the screening modalities for a line, you'll see that, you know, only 44.4% had acceptable echo quality by core lab analysis. Only 17.8 had good quality, and, you know, over 20% of those were inadequate or poor. So echo seems to be a very challenging technique in terms of AR. And there was basically no MRI done for these patients. It's 65% is transthoracic and it's 34% it's transesophageal. And as you can see here, it's pretty hard to quantify all parameters as we just discussed before. This is the number of values or the number where these values were done and had a, so this is the number of, so this is the percentage where these values had a good, where geez, this is the number of this is the so was it good or not? That's basically shown here, and you see that 70.2% of patients only had a PISA, and basically nobody had vena contracta 3D. Even 2D regurgitation volume or fraction was quantified not very commonly. And it gets even more interesting if you look at a correlation of MRI and echo. So this is echo severity against AR severity in CMR. And you'll see that, the severe patients are orange. So only 44.7, not even half of the patient had an agreement in severity in MRI and echo. And there are over 30% of patients who are severe in MRI, but are not severe. They are moderate or mild in echo, which means I don't think that TTE is our best diagnostic tool, and we are not allowed to stop with moderate AR. So if it's moderate AR, we have to follow up. We have to do a TOE. We have to do the MRI. And is MRI helpful? Well, some newer studies show that it might even be able to tell us a little bit more about our patients. And if you look at this, these are cumulative incidence of primary composite endpoints and outcomes here. And this is stratified via regurgitation volume, fraction, LVESD, or index LVESD. And you'll see that these endpoints in this study here from Malahafi are shown and separately. They show good separation with even lower values than recommended in the guidelines. So you see, it's not a 60 ml regurgitation volume. It's not a 50% regurgitation fraction. It's even lower. It's an LVESD of 4, not 5, and 2 indexed versus 2.5 in the guidelines. And we have clear separation. So I think this is one of the first pieces of data that I wanted to share to underline that I think the guidelines are too old and need to be re-advised. But, all right, we've diagnosed now that we have AR, and if we want to treat it, does it actually make a difference? Well, I can tell you if we don't treat it, that's a 34% mortality at 10 years. That's 5% a year. But if the patient is symptomatic, the mortality increases to 10% a year. And if the patient is highly symptomatic, the mortality of those patients are 25% a year. And there's no way we can stop this when we use medical therapy. So every study in this meta-analysis, or every study I looked at, is medical therapy can help you to control symptoms in your patients, but it does not help to prevent disease progress. So I think it's a very important point to make that at some point we have to deal with more than medical therapy in these patients. Medical therapy doesn't help us here. So this is reflected by the guidelines. We have clear recommendations in the American and in the European guidelines that if we have aortic regurgitation, we wait for symptoms. So symptomatic AR that's severe has a clear indication to undergo surgery. But also we have to wait for a decrease in ejection fraction. And remember the numbers I told you, if the ejection fraction decreases, there's a lot of volume already on the ventricle. There's a lot of stress already on the ventricle. Or we have to wait for LV remodeling in asymptomatic patients. For example, in the European guidelines, it's 25 millimeters per meter square LVESD, which is a huge dilatation and LV remodeling. And we've seen before that in MRI, we can have a separation of outcome curves even in lower values. This is further underlined by these studies. So the gray zone kind of is LVESD indexed 20 to 25. And if you look at these patients, they get AVR within 6 months. So they get treated even they're not perfectly in guidelines. They are way better than patients that have no AVR within 6 months. And if you look at the MRI data, the sweet spot in terms of 5-year mortality is definitely closer to 20 LVESD than to 25. So I think, these guidelines are maybe a little outdated, and we need more data to support that. We need to push it a little further. But when we treat our patients, do we actually help them? And yes, if we perform surgery, we do help these patients a lot. If you look at those patients, there's a 2.7-fold increased risk of mortalities in patients who fail to undergo surgery. So surgery really helps those patients here. That's the red curve. And that's, interestingly, that's true for patients with low EF and with normal ejection fraction. So even patients that already have severely impaired LV function will in the end, it will be a profitable outcome if they get surgery. But, and that's Turani et al. 2021, over 4,000 patients, only 25.7% of patients in this control cohort underwent surgery within the first year of diagnosis. So that means on the other way around, that in this population, only 75% of patients did not receive surgical treatment within the first year of diagnosis of severe and symptomatic aortic regurgitation. And it gets interesting if you look why these patients are not referred for surgery. So the patients not referred for surgery are the older ones, are the ones that are female, and are the ones with low ejection fraction. And also, it could be shown that the primary cardiologist impacts the likelihood of surgery undertaken in these patients. So I think that's a sign for me that I need to talk more a lot, and we all need to talk more about a lot more about AR and how important it is, and to show the referring and primary cardiologists that we actually do have a solution with surgery and maybe even with TAVR further down the line for these patients. Because the question is, if we don't want to undergo surgery in these patients, maybe we can find something interventional for them. Because I mean that, in that comparison, I would clearly go for, the little small 6 French sheet, right? It's not actually 6 French, but it's better for the comparison. So, but if we look at older data, it's really not fun data to look at, because this is second valve implantation. So in an old cohort, we had in a quarter of patients, we had second valve implantation, right? So that's definitely something that we would not consider a perfect setup. Furthermore, there's more than 15% of moderate AR after TAVR. Again, this is not something that we strive for, right? But it's older data, that's TCT 2018. In the older data also, the patients with aortic regurgitation had worse prognosis after TAVR than the patients with AS. So in this time, we didn't have the tool to treat these patients as good as our AS patients, also underlined in this meta-analysis, still 8% all-cause mortality. If we have 8% all-cause mortality in our aortic stenosis group, I think then something is wrong, right? So this is not something we would be happy with. A little better, but still not perfect, are newer data. This is 2017, this is 2023. That's the Pantheon registry right here. Still, we're getting better results with the new generation devices in terms of second valve implantation, still 13%. We still have 4.2% of severe or moderate AR, and we have 20% of absence of device success. That's definitely not perfect. In the Pantheon trial, we had 12% of TVEM. TVEM means transcatheter valve embolization or migration. Again, that's not perfect. So I think what we need and what we want are dedicated devices for the treatment of AR. And why is that? And I really like this picture because, to be quite honest, I mean, this is how I imagine a severely calcified stenotic aortic valve. And if you treat this, I mean, the valve is going to hold. No worries. We put a TAVR and we push this calcium to the side and it's going to hold. But here in the aortic valve regurgitation, we have minimal or absent cusp calcification. We usually have dilated aortic roots. We have dilated annuli, which means we tend to use the bigger valves we have, which probably leads us to less oversizing. And it's really, we have frequent coexistence of dilated ascending aortas. So I think, it's a different animal. It's just a different game to treat this versus this. And fortunately, in Europe, we got CE mark for Jena valve in 2021, and Jena valve applies a different concept of TAVR valve to that space of aortic regurgitation. And what it, what makes it special, I think the thing that makes it special are these three locators. It also, has a pretty good sealing ring down here. It has large open cells, but the main issue, the main thing, the main feature are these locators, because each locator goes into the nadir of one of the coronary cusp of the aortic valve. And with that, you have sealing for sure, because once the valve open, it will, clip onto the valve, onto the native aortic valve using that clip mechanism, because the sealing ring gets outwards and the locators stay in place. But, and I think that's most importantly, once your locators are in place, there's no way you're going to move the valve ventricular. So you have no ventricular migration. And also, after the clipping mechanism is in place, we don't know how much we need the clipping mechanism yet, or how much oversizing we can actually use. Can we do single digit oversizing? Can we do no oversizing? But it also, I think the clipping mechanism helps us with holding the valve in place in terms of aortic or our aortal valve migration. And the interesting thing about the delivery system is it has this little system back here, which would help you rotate everything. We'll see that later on. And because you, of course, have to align the locators to the nadirs, and a very long sheath that will stay in the STJ for a part of the procedure. And together with 5 other centers, we were very, very happy and honored to collect data of the first 58 patients we treated. And you see, this is not bragging. This is, I hope that, it's clear that it's just a different, it's a different set of valves we're using for patients we didn't have something before. And now we have device success rates of 98%, which, I think is something that puts it into perspective of TAVR and AS. So now we have something that we can actually offer patients to treat their AR interventionally without surgery. So we had 98% device success, 100% technical success. We had no PVL that was bigger or was moderate or bigger. And we had very much increase and a very good improvement in New York Heart Functional Class. The thing that I would like to discuss in the end and also focus a little bit later on is the 19.6% pacemaker rate. Keep that in mind, okay? What kind of population did we treat? I mean, that's for us a very typical TAVR population, to be honest. It's a mean age of 76.5. We have a Euroscore 2 here, and that's the STS predicted mortality. So it's 4.2 or 6.1. So it's kind of like intermediate risk, but probably on the lower end. And all those patients were severe AR patients. Mean gradient was 8.7, so no AS. The thing that's probably more important to you US guys is the ALIGN trial. And I want really to dig a little bit into that ALIGN trial, because this is hopefully the trial that would get the valve FDA approval in the end. And it shows also very good safety endpoints at 30 days with all-cause mortality 2.2%, and a very good, safety profile. It also shows great hemodynamic valve performance, as we've seen in the European cohort as well, and also, almost no moderate or more parallel regurgitation. So let's dive in here a little bit more. In the end, it was 180 versus it was 180 patients that had, from out of 380 patients that have been screened. There was a huge dropout rate with 199 patients, usually due to CT anatomic criteria and other clinical and anatomic criteria. 40%, so also a significant amount, only had moderate or less AR. Keep that in mind. I think that, treating moderate, so moderate is nothing you can hide behind. So you have to find out if moderate is really moderate or if it's more. So probably if we look at the study population now, maybe, this is something that we could argue about, but in the end, it was 180 patients. Same profile, basically, than we've seen in our European cohort, 75 mean age, SDS score 4.1, and they were all highly symptomatic. And compared, so as this was now a randomized trial, we can see here the primary safety endpoint of this study. This is a performance goal derived from contemporary high-risk AS TAVR trials, and it was significantly lower than that in the primary safety endpoint. So the non-inferiority criteria were met, and the same is true for the primary efficacy endpoint at 1 year, which compared it, to be honest, not with surgery, but compared it to 1 year mortality weight with conservative management according to New York Heart Association class. But again, here, non-inferiority criteria met. And also, these patients had significantly improvement at New York Heart Functional Class 2 and quality of life. Look at this. This is 20 points in KCCQ. I mean, also something that we can discuss later on maybe. But if we go to the tricuspid valve, the one we focus a lot on right now, also. If you look at TriStent, if you look at Triluminate, 20 points in QCCQ is quite a deal. So I think this is really significant data. And if we compare Trilogy, the Jena valve, which is also called Trilogy, if we compare Trilogy with other trials and other valves that might be around and stay around for AR as well, like the J valve, which is in compassionate use right now, and the My valve, which as the octa-core goes up to a size right now from to 32. So in big annuli might also be an option, and they published their AR experience as well. You see that, the SDS is kind of like in the middle for the Trilogy. They have the best device in technical success for now. The pacemaker rates are 24%, so pretty high. Again, I said we focus on this a little bit more later. But, almost no moderate AR and no valve embolization, very good safety profile. If we look at the pacemaker rate, and that's what I wanted to stress is, during the trial, there was the oversizing. So basically the sizing chart was changed a little bit with less oversizing further down the line. And also, I think we learned to implant a little higher over the years. And you can see that in the first 60 patients, the pacemaker rate was 30%, whereas in the last 60 patients, the pacemaker rate was 14%. I don't know if you've noticed, but also in all the other non-dedicated devices and in all the other trials and data looking at AR, pacemaker rate is around 20%. And I think that this is, and for surgery, by the way, it's not 4 or 5%. It is in some registry data, at least around 10%. So AR itself seems to be a little bit more prone to pacemaker risk in terms of aortic valve replacement or TAVR. And I think one of the reasons is the lack of calcium, because the oversizing you apply will directly interact with your annulus and this, depending on patient height, membranous septum height, and stuff like that, you will get interaction with your AV node and with your conduction system. And therefore, I think we haven't found out yet perfectly how to get pacemaker rates down, but less oversizing and higher implants might be a way. Also, I want to show this. I focused in the beginning of explaining a little bit about LV dysfunction in AR, and you can see that all the patients that have been treated in the ALIGN trial improve in every LV size variable, right? So we have positive remodeling after the treatment of AR. And again, the central illustration here from the Garcia publication from 2023 shows you another candidate as a dedicated device, the J valve, which I think, has a similar concept kind of with these arches instead of locators. And the compassionate use data looks pretty promising. So let's keep our eyes out for this valve a little bit. And, there are some Chinese valves already that, kind of look like in between. And there was, little letters and references to that there might be some valves more coming up. giving us more tools to explore dedicated devices for treatment of AR. And I think, that can be something that we can offer those 75% without surgery in the first year after diagnosis. And I know it's a cath lab talk, so enough of the theoretical stuff. Let's do some practical work here. That's one of the cases that we treated with the Jena valve, and I really wanted to share with you how this is actually looking hands-on. This was our patient, 78, female, very small person, type 3 morphology, very, very severe impairment of LV function. She actually was diagnosed with AR 2-3 years ago, but never cared to go for a referring cardiologist. And so she came into the emergency department with heavily decompensated chronic AR. CT, very typical for a patient with AR. There's literally no calcium, just little tiny spots here in the left main and the LAD and the circumflex. But, torches, non-calcified vessels, good access, a little tortuosity of the aorta. And we decided to treat this patient with the Jena valve. This is just a schematic, so, to train our pattern recognition that we see in the case now, that we're going to see in a second, how, things theoretically should look like. Long sheath goes into the arch, stays in the STJ, then the delivery system is applied, the sheath is pulled back, the locators get exposed. We then, by using the handle and the turning knob here on the handle, we can then adjust the locators. We're going to perform a C-arm sweep to make sure that this locator really is in front and not in the back. And by sweeping the C-arm, we can actually find out if it's in the front or in the back. So if it's in the right or opposite the right coronary cusp, we deploy the valve, get the system out, and then the patient usually has a good result. So Jena valve implantation in 3 minutes. I'm going to walk you quickly through it. We have a Safari wire and an MP cath in the patient. The MP is so that you can specifically and very easily look at each coronary cusp itself. So you need this for isolation of the cusp later to confirm that your locators are in place. The sheaths will be advanced. In this case, we use TOE. We've done many cases now in conscious sedation without TOE, but in the beginning, or if it's a more complex case, I think it's really helpful to have TOE also. The sheath goes into position, then the system is going to be inserted. And this is how it looks in the real world. You have these locators here, 1, 2, and the third one is on the back. And you will, this is the valve is held in place here by this insertion help. And now you put everything into the sheath and advance it along the long sheath. 1, 2, 3 locators, radio pack markers right here. Good sleeve coverage. So the distal part is really, the valve is held in place very nicely here for now. So that's a good. So this valve is ready to get exposed and to get implanted. Just make sure you're not too deep and not already interacting with the anatomy of the aortic valve. Stay above the STJ. The sheath will go back now. You see that this marker band is actually pulled backwards. The locators get exposed. We'll give a little flex on the system. You can see that the locators will already start to spread out once you separate a little bit the active part from the passive part of the delivery system. You see now the locators spread out. And then you can separate the system a little bit further, which gives you the space to rotate and to go more ventricular or artery. This is the C-arm sweep. You see that the middle locator actually moves to the left coronary side. And you have to believe me, if you go from LAO to RAO and the middle locator moves to the left coronary side, it means it's in front, which indicates it has to be in the right coronary cusp. You can also, advance and rotate, as we've seen in the video before in the animation, the system. So that's what we did. We were pretty sure that we're in a good position here. We pushed the valve a little deeper. Now you make sure with the help of that MP that you have one locator in each corresponding cusp, and then you will deploy the valve. It's a very fast deployment. It's a self-expanding valve, of course. Fast pacing is helpful here, but I think not mandatory, but we always do it with fast pacing. And then you taper down your pacing a little because, you know, there's no calcium. So you don't want to end up with a high stroke volume of a heart rate of 20 after almost complete heart block. So taper down your pacing a little bit. And that's the shot that I think is very satisfying in the end. Valve is in place, locators are in place, there's no AR, gradients usually are single digit, and that, you know, that's the case without PNA valve. I think, you know, these are the cases where your heart rate goes up a little and you're not sure if that valve stays in place if you use a non-dedicated device. So overall, in conclusion, I would like to make those couple of points here. So I think relevant aortic regurgitation is more common than you initially think. And we need to improve our diagnostic workup. We need to include TOE. We definitely need to include MRI. And you guys have very good imaging experts in the States. So I think making use of them is probably a very good idea. Don't stop at moderate. I think moderate AR is an excuse. If you see moderate AR and TTE, that is, you're not allowed to stop there anymore. You have to do TOE. You have to do MRI to find out if that's really only moderate AR or if it's more. We need to work on our guidelines. I think they've you know, served us well, but for now, I think the cutoff LV diameter and RV regurgitation volumes are most likely not perfectly correct. And for now, we only include patients that surgery needs to be performed after symptoms and LV remodeling or dysfunction. So is that really true? We have to find out. We need more data. I think we can definitely make the point that we have an undertreatment of AR with surgery. Maybe not as dramatically in this one cohort, but in this cohort, I mean, we had 25% who did get surgery. That's not, you know, that's a quarter of patients, 3/4 of patients will not get surgery in the first year. So we definitely need to improve because untreated AR has a mortality rate of 10% per year, at least. If they're severe and symptomatic, it's 25% per year. And I think that I can make the point, because I've done it a couple of times, many times before I had dedicated devices, off-label TAVR with, you know, certified devices for AS, but not for AR, usually really is no fun. So I really like dedicated devices because they show great results. We have European data now, we have the Align data. We have more data coming up. Device success is high. We have no PVLs, no moderate PVLs. We have low gradients, and we've starting to understand if pacemaker rates can be brought down a little bit more. And I think, you know, let's start and get these devices in the undertreated patients that need some TAVRs. And in the end, because I spoke about paradigm change and paradigms, the guy sitting right next to me is called Elmar Kuhn. He's not related with this guy, but there's a US philosopher and scientist, Mr. Kuhn, who invented the Kuhn cycle. And I think we're somewhere here right now. We have some pre-science. Now we, you know, apply more science to that problem of AR, and we're starting to let our model drift, and we're not yet in model crisis, but I think we should push above that point and revolutionize how we think AR, because then we can change the paradigm. That AR is not common, that AR doesn't need treatment, that severe AR is nothing to worry about, and that I think we need to treat these patients earlier, but of course, on the basis of science and not pre-science. So thank you very much, and I would be very happy to, you know, discuss with you guys what you think. Okay, so thanks from Cologne. This is our heart center.
Matty, thank you so much. That was, I think, one of the best talks I've ever heard on AI and the treatment of it. And was also very clinically based, which I appreciate because we have a lot of our colleagues who are non-invasive as well. And I think, you know, I think they appreciated the clinical basis to it, and that, you know, we structuralists also are good clinicians, and think about the clinical part. Um, the other thing I wanted to mention, because I see a lot of our colleagues on, is just for them to know that, we are at Monty involved in these clinical trials with AI. And so we actually have one starting this month. So if you have patients with AI, don't know that we do have dedicated valves right now. So we have some of the fellows on, Maddie. I have lots of questions myself, but I always like to open this up to the fellows
Sure.
first, and then we can go. Do you have any fellows? I saw Jonathan. Do
Yeah,
you have
Jonathan. I mean,
anybody else on your team?
I think Jonathan is the one who is joining from the Cologne side. I mean, it's
Okay,
in the middle of the day, so they're usually in in
no
procedures
worries.
like that. So
Yeah.
Jonathan is probably holding up the flag of Cologne here.
No worries. Okay. Well, let's Andre, you had a question. Let's start with you.
Yes, hi, Matti. Thanks for this
Hey,
amazing.
Andrea.
I have just one question. I like your slide when you say that the most common causes of AI for secondary eye are bicuspid and aortic dilatation. So in cases of aortic dilatation, let's say we implant this valve, should we expect, let's say at long term, some complications like PVL or valve embolization if the aorta continues to dilate? What do you think?
That's a very good question, Andrea. So I think that so nobody knows for sure to say that, I think, because we're only, these patients who were not operated on and dilate so much that they have, 6 centimeters of aortic root or ascending, and that we now do TAVRs on, that's not so many patients that I think, have good data on them. But one of the main reasons that the aorta will dilate is the aortic regurgitation and the change in flow patterns in the aorta. So one could argue that with the treatment of the aortic regurgitation, the progression rate really comes down, right? I think there is some MRI data now trying to look at this. So, I think we should undermine this with more data. I'm, for example, aware of some data for bicuspid patients that when we treat them, their anatomy will increase slower after treatment with a TAVR. So their dilation is slowed down by treatment of the valve, but only if you don't leave moderate PVR or more. Then these patients progress faster. So the point I want to make here is I think that the aorta is diseased and probably it will have, Laplace law. So if it's already dilated a lot, then it will, more easily dilate even further. But if we treat the underlying reason, the AR in this case, or the bicuspid in the example I just gave, the progression rate will slow. And that will even be more the case when we leave a perfect results with our TAVR devices. But it's a very good question because, these are the patients that you need to argue with your heart surgeon because you really want to make sure that it's not that's a candidate not suitable for surgery because if they die of rupture half a year after your TAVR, then I think you've done maybe you've been in the wrong. So that was probably the wrong choice for this patient.
Yeah.
Thank you. So you say that you have experience also on bicuspid valve. They are currently excluded here in the US in both the Align for Jena and also the J valve EFS. What's your experience on bicuspid valve? Because you have these three locators. What does it change?
To be quite honest, I don't have experience with bicuspid valves and Jena valve. So for now, I'm still kind of shy. I don't want to push it so hard. I mean, bicuspids, of course, is a variety of it's a melting pot of diagnosis and aortic stenosis, AR, anatomies, type 1, type 0, big calcified raphe, small raphe, and so on. You guys all know that. But I think there could be in a type 1 by anatomy, I think there could be an advantage of using a Jena valve. And I know that the transapical system that has been around 10, 15 years ago, that has been used in bicuspids and with some okayish results. Some of them come back now with valve degeneration. So I think, if you don't have perfect expansion of the valve, it might be difficult. You still get the oval shape. So I think I don't know yet if it's a good valve for bicuspid, but I would love to see more data and try it out. And it might be useful because valve migration can be a problem also in bicuspids, as you all know, especially if you have a taper anatomy or something like that.
Hey, Maddie.
Hey, Azim.
So I have Edwin Ho here too, who, as you know, Edwin is in charge of all our structural imaging, interventional imaging, and he's very involved in the TAVA program. So I was going to ask him to maybe comment. You know, I was really moved by what all the discussion about how often we underestimate AR on TTE, on echo. And I agree with you. I think we need to be using more MRI in our evaluation. But as we both know, MRI is not always easy for some patients. They don't like to be in the MRI machine, or maybe they've had surgery that doesn't allow them to have MRI. So I wanted maybe Edwin to comment and maybe share with us, what else can we be doing from an echo perspective to try and understand the severity of AR. And I also, maybe it's my first question, my second question for him is there a role for exercise echo in these patients to understand symptoms and severity?
I think two really good questions. My main comment about the echo part is, we rely heavily on Doppler-based parameters, and for a variety of reasons, there can be a lot of errors, especially with eccentric jets. So I think that in this talk, as we heard, I think absolutely there's a huge role in modalities like MRI, things that will give us more volumetric-based evaluation. I think we always try, of course, in echo to quantify this correctly, but it can be really, really challenging. I think that, the better the image quality and the acquisition, of course, of data sets, then the more accurate we potentially can be. In terms of the question about exercise, that's also a really good one. I think in valvular heart disease, we deal with so many of these dynamic lesions that definitely will change with exercise. The data is probably a little bit less robust on the aortic side compared to mitral, for example, but I think there's generally a huge role in exercise testing. It's probably underutilized in valve disease all across.
Yeah, and part of Maddie, the way the reason I bring this up is part of the challenge here in the US as we are designing now, clinical studies, for example, with J valve, is the fact that the US guidelines are a little different to the European guidelines, right? So the US guidelines also give a class 1 for symptomatic patients, but for the asymptomatic group, even with LV dilatation, they give a class 2A indication. And the problem is when you have a class 2A indication, you can't use that in a clinical study, right? So when you do a clinical study, it has to be class 1 indications that you put as your inclusion criteria.
See, there's another reason why we need to move those guidelines, right?
Exactly. It's crazy that we have to wait for patients to be symptomatic. So
Yeah,
you can have severe AI, and you can have a depressed ejection fraction of 40%, okay? Yet the guidelines say if you're asymptomatic, it's a class 2A indication.
And that's a very good point you're making, Azim. After one of those talks, I had a guy coming up to me and he said, I'm a cardiologist, and I usually see patients who are very competitive in sports. I had a patient who would compete on federal level, and he had severe AR, and he was still very highly successful. And he said, I cannot be operated on right now because I really want to be in the games. And after that, he got treated and felt better. But before that, you would not think that this patient is symptomatic. He was competing on a federal level. Right. And of course, there are these patients who can compensate and who still, have less symptoms than, and that's the point I want to make, than a patient with AS where, symptoms are pretty clear. They have dyspnea, shortness of breath. they have angina, and you know, and they get unconscious. But for AR, we really need to fine-tune how we ask them for symptoms, how we look at their ventricles, because I think in the end we want to prevent that their ventricle gets irreparable damage. So that's where MRI can also help us a lot to understand when we need to treat those patients. And I don't want to say that we have to treat every asymptomatic patient. That's not my point. I think I'm just trying to make the point that if we wait for symptoms or structural, severe remodeling of the ventricle, then we might sometimes be too late.
Yeah, absolutely. As you know, one of the other persons on the call is Aldo, who I'm not sure he can speak now, but Aldo is very involved in he's very involved in our advanced imaging in CT and MRI. So Aldo, I'm warning you, you're going to be getting a lot more MRIs from for AI. We also had Stefan Nina, but Stefan, did you want to ask a question or make a comment?
Stefan is actually one of our fellows as well. So
Okay,
hi,
cool.
Stefan. Good to see you here.
You can take yourself off mute, Stefan, and ask the question, or put your microphone. You'll put your camera on microphone.
Maybe he's seeing patients that
Yeah.
I should see.
Yeah.
So, well,
So he did put a
he
question.
wrote a text. Yeah. He said, is there any data which, oh, there he comes. Come, Stefan. There he is.
Okay.
I unblur my screen. Hold on.
Okay. There you go. Hey, Stefan.
That's Stefan.
Hi, nice to meet you. Yeah, I wanted to ask if there was any data that is known which compares TOE and MRI in the setting of diagnosis of AI, because we just saw how we compared TE and MRI and underestimate the incidence of AI. But yeah.
It's a very good question, Stefan. I don't know, Edwin, if you know, or so I think that Zhao got the same question in London valves, and I'm not quite sure how he answered. But I think what we can say is that TTE probably is a good screening tool. And if we use TOE, we will most likely get the patient classified more correctly. So I would assume that if we do the same, graph bar plot with TOE against MRI, there will be more overlap in TOE and MRI. Because what for us usually happens is we see a patient with moderate AR and TTE, and then, in a significant number of cases, when we do TOE, all of them get TOE now. That's our routine now.
Yeah.
If they get TOE, we usually, there is a large amount of patients or a significant amount of patients that we classify higher. So I think this group of patients that, that we miss for moderate in the severe MRI group, I think those we can improve on with TOE. It's still not going to be a perfect overlap, but I would assume that TOE really helps us a lot.
I think we're going to learn a lot here. I don't think we've fully exploited 3D, and 3D quantification and echo on how we measure AI and the severity. So, we're currently designing the pivotal study for J-Valve, and Zhao is going to be the core lab, So we're hoping we will get really good data on CMR, TE, exercise echoes, and be able to start doing some comparative work to understand, how we can use maybe more non-invasive testing and things like echo to get a better evaluation. So I think as we get more data, I think that'll be very useful because, we're also looking for, for data for exercise testing and for exercise echo to try and understand, because like I said, we have this problem in the US that patients have to be symptomatic to have a class 1 indication. So, someone whose EF is dropping or alveolar volume is dilated or has severe AR, do they have symptoms that we can induce by exercise testing, for example? There's no data on this for AI. So there's a lot of work we have to do there.
And Azim, I think that's a very good point you're making. Because exercise testing has also helped us for AS, right? I mean, there is good data underlying that patients get symptomatic in exercise testing with AS, that they are the ones you should treat as well. And if they get signs of ECG, so if you see ECG changes, if you see hypotension during exercise, and I really like the point you're making that we need to find out what are the things that we need to look out for AR patients, right? I mean, that's a very, very, very important point that you made. Yeah.
So the last thing I'm going to ask Jonathan to make one comment too, because he's been very quiet, which is unusual for Jonathan.
I don't know. Maybe he doesn't get a cold or something. I don't know.
Maybe he lost his
I
voice.
was just waiting for this comment of yours, Azim. That's it.
So is it AR or is it AI? So we all agree. Are we going to call it
So-
AR or AI?
I think with you guys it's AR, but I just did write a German article, and for us it's AI, like the artificial intelligence.
You see a few Germans confusing us again.
As always. But in the end, we will also have the solution. Don't worry. Maybe just now that I'm like speaking as well, Madi, maybe as we're going to the end, a bit of like questions that maybe look a bit into the future. You nicely combine these things of data and then also technical stuff that you showed. From the data side, as you said, there needs to be this paradigm shift. So if we look from the interventional perspective, how do you think next studies from the interventional side should look like? In AS, we had this, like you go through the risk strata against surgery, but here you said like already with surgery, we have an issue and we are coming too late, etc. So should now the interventional trials try to make this paradigm shift, or do we first have to compare against surgery? And from the technical aspect, I'm more and more wondering whether with these clipping mechanisms, this is kind of a third platform of devices, so balloon expandable, self-expandable, and then clippable valves. Do you maybe think that there is a role beyond AR, AI, and what kind of patients could that be?
All right, Jonathan, good questions. You can stay in Cologne if you want. No,
most definitely will.
Thank you, Jonathan. It's great questions. So I think one point that you're making is really good is what kind of trials do we need? And I think it is, as always, a debate of, I mean, first of all, we need to get FDA approval in the States, and you know, so that's I think an important point. But I think it's a debate on what we want to do and what we need to do to check all the boxes. And I think one good trial could be randomization of surgery versus interventional therapy. And then I think it's a little bit of an argument with the FDA, for example, if you want to go for low-risk patients directly, or if you still need to go through the, you know, intermediate and high-risk surgery groups. So of course, what I would like to see is randomization against surgery in low-risk patients and all comers, right? Yeah. That would be the perfect trial. The question is if the FDA and our regulatory let us do these trials. Another question that I really would like to see, and that kind of maybe refers to a little thing, you know, to what I said just before, is if we can dissect out which patients with moderate to severe and maybe less symptoms would benefit from earlier treatment, that's another good trial. And then I think you probably still need to randomize them against surgery or medical therapy. That's, you know, depending on how you want to design the trial. But if you find out, let's say, moderate AR plus elevated BNP, moderate AR plus elevated troponin, moderate AR plus exercise stress testing that indicates it's not the patient that's perfectly asymptomatic, moderate AR plus has been decompensated, moderate AR LV function increase of 5% over the last 6 months, something like that, right? So you need to find the high-risk moderate AR group and then see if treatment actually benefits them. And then you can change the guidelines. That's another good trial I think I would love to do and see. The clipping mechanism, I mean, I've never thought about as being, you know, the third group, but that's a nice idea. We should spin this a little more. We have done UNAVEF cases in AS patients, and they were also extremely well treated patients. They had no PVLs, and the pacemaker rate in the AS patients was 2%, so really low. So no PVLs, single-digit gradients, and 2% pacemaker risk makes it, I think, also a valuable valve for the AS market. But I mean, in the AS market, there's a lot of competition going on right now. and it's all about, numbers, 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 and fast deployment. You would get perfect coronary alignment per definition if you implant a Jena valve in an AS patient, which will help you a lot further down the line with, with lifetime management and stuff. So I think it's also an idea that we should not keep out of focus. It's a very important point, but I think the AR patients are the ones that are undertreated right now. So that's the point I wanted to make for AR. AS, I would really love to use this valve more for AS, but for now I'm just using it for AR patients because I don't have as many valves as I would need.
Yeah, absolutely. Manaf, last question to you, or comment, and then we'll close. Maybe he can't talk. Manaf is one of our. You're still on mute, Manaf. Maybe he can't talk. Manaf's one of our structural attendings. Matty, I think we're going to stop there. Thank you so much. This was like a great session. I learned a lot. I think everybody who was here learned a lot, and it was amazing discussion about AR. I'm going to stick with AR so I don't get confused with AI. And I think the role of new valves, and we've been behind a little bit in the US in this, with this. But I think it's an exciting time because we now have J valve in clinical studies, and hopefully
really
next
see that
year,
one. Yeah,
J valve is interesting because they have a 31 and 34 millimeter valve, okay, which having done Jena valve, that many cases you turn down because the annulus is too big, right?
Yeah.
So I think I'm excited about that, seeing how the bigger valves do in AI, and then next year we should also have the Jena valve approved in high-risk patients. So it's an exciting time for AR, but like you said, still lots of unanswered questions and a lot of work to do to raise awareness.
All right, Azim, thank you very much. It was an honor to be invited, and it was great seeing you guys.
Thank you for taking the time. Okay. Happy holidays, Merry Christmas. Okay.
Same to you. Bye-bye, guys.